Hello everyone, I am Dr. Sneh Verma from the Department of Orthodontics, School of Dental Sciences, BBD University, Lucknow. In this lecture, we are going to talk about management of class 2 malocclusion. As we all know, Engels in 1899 classified the malocclusion into three groups, class 1, class 2 and class 3. Class 2 malocclusion said to be exist when the distobuccal cusp of the upper first permanent molar occludes in the buccal groove of the lower first permanent molar, and secondly, the mesial marginal ridge of the upper first permanent molar contacts and occludes with the distal surface of the distal marginal ridge of the lower second premolar. Then again, Engels has subdivided the class 2 malocclusion into two divisions, class 2 division 1 with the clinical features of proclined maxillary incisors, and class 2 division 2 with the retroclined maxillary incisors that can be further subdivided. One more classification, class 2 division 1 subdivision was given when on one side class 1 molar and another side class 2 molar exist. This is termed as class 2 division 1 subdivision malocclusion. Class 2 division 1 malocclusion has some characteristic features. Here is the list of extraoral features, which includes convex profile, everted lips, incompetent lips, dolichocephalic pattern as we can see here, and the leptoprosophic face. There is a evident presence of abnormal muscle activity. Here you can appreciate the upper lip is usually hypotonic, short, and fails to form a lip seal, that is incompetent lips. Whereas lower lip cushions the palatal aspect of the upper teeth due to increased overjet. This is a typical feature of class 2 division 1, and this condition is referred as a lip trap. Also, there is a hyperactive mentalis activity evident by puckering of the chin when patient closes his lips. Intraoral features include class 2 molar and class 2 canine relation as well. Proclined upper incisors with resultant increase in the overjet, and deep incisor overbite can occur in the anterior region. Intraorally, there will be a deep high arched palate, and the tongue occupies a lower position, thereby failing to counteract the buccinator activity. The unrestrained buccinator activity results in narrowing of the upper arch at the premolar and canine regions, and thereby producing a V-shaped or narrow upper arch. Coming to the management of class 2 malocclusion. The question arises, why to correct class 2? The first and foremost reason is the aesthetics. The major reason people seek orthodontic treatment is to minimize the psychosocial problem related to their dental and facial appearance. So well-aligned teeth and a pleasing profile and pleasing smile carries a positive status of all social labels, whereas irregular or protruding teeth carry negative status. So aesthetic is a prime concern to correct the class 2 malocclusion. Then function plays also a major role, as patients with anterior open bite and increased overjet and all these, they compromise all aspects of oral function. Patients with open bite or with marked overjet often complain of difficulty with eating, particularly while incising the food. Trauma, increased overjet results in more chronicity for the trauma. Whenever if child while playing he gets fallen off, the most common fracture of incisor teeth occur. TMJ problems. The relationship of malocclusion and adaptive function to TMJ are manifested as TMD, that is temporomandibular dysfunction, and the pain may result from pathologic changes within the joint, but more often is caused by the muscle fatigue and the spasm. Periodontal problems are also a reason to correct the class 2 malocclusion, because traumatic overbites can also lead to increased loss of periodontal support, and therefore are another indication for the orthodontic intervention. Treatment planning based on mainly on the three criterias. It depends on the nature of malocclusion, it depends on the severity of malocclusion, and also with age of the patient. How the nature of the malocclusion? We in the different type of if the nature is skeletal, dentoalveolar, functional, or combination of all these three things. So depending on the nature of malocclusion, our treatment strategies will vary. And similarly, according to the severity of malocclusion also, if it is mild, moderate, and severe, it can be graded. And depending on that, the modalities, treatment modalities will again differ. Age of the patient plays a major role in defining and deciding our treatment plan. If there is a growth remaining, we have a different modality we will plan, and after, if there is a no growth, the modalities will be totally different. So here comes the role of envelope of discrepancy. It is given by Epker and Fish. This envelope describes the how much amount of changes we can get by the orthodontic treatment. Here it is an envelope of discrepancy for the maxillary arch, and here the circles which describes, these are the extremes which describes the amount of changes we get by different modalities. As in orthodontics, we have myofunctional appliances, we can do the go for the fixed orthodontic treatment, or we have surgical approach. So these envelopes, these this is the inner envelope, this is middle envelope, and this outer envelope, they will it will describe the to which extent we are able to do the achieve the correction for by the myofunctional appliances alone, or with the this is for the orthodontic treatment, and this is final by the surgical treatment. So in all the three planes of space, that is anterior-posterior direction, in the vertical and in the transverse direction also, it will define the how much amount of effect or treatment results we can get. This envelope describes the range of treatment to be achieved, correction to be achieved in the mandibular segment. So if we briefly describe the class 2 malocclusion, as we said, our treatment plan will differ according to the growth remain or growth completed. So in a growing patient, it will, if it is a mild or severe or moderate, so if mild, then again, in both the cases, we will try for the growth modulation procedures. If it will be mild, it will be completely corrected out. But if it is a severe problem in growing patients, at least severity can be reduced to certain extent, that so that the phase 2 treatment will become easier to carry out. So in the non-growing patients, if there is no growth remaining, so we can't go for the growth modulation procedures. So then only we have only two things remains, which are the orthodontic camouflage or the orthognathic surgery. So depending on the severity of the case, in both the cases, if it is not so severe, we orthodontic compensation, we will find out if there is a compensation is there or not. So camouflage can be tried out, and if compensation has already been there, so decompensation, and then finally the severe in severe cases, orthognathic surgery is the option. So general strategies for class 2 correction will involve, as I said, we have a growth modification procedures and orthodontic camouflage and the orthognathic surgery. So in growth modification procedures, we have we can go for the differential restraint and control of skeletal growth by the extraoral traction by the headgear. Differential promotion of the skeletal growth can be done by the functional appliances. Camouflage treatment involved, that is the to conceal the problem, that can be done by two processes. Two things are there. We can go for the extraction treatment, or we can elect the non-extraction treatment strategy depending on the severity of the problem. Surgical translation of parts after growth completion, that is in the severe cases, as I said, so option will be the orthognathic surgery. So orthopedic devices used in treatment of class 2 for the growth modulation procedures to restrain the growth. Here we have, as we know, in the class 2 cases, there is the problem may exist in the maxillary base or the mandibular base. So if there is a more growth of the maxilla, so we have to restrict the growth of the maxilla, control the growth of the maxillary base, and that can be done with the help of orthopedic appliances known as headgear. Headgear can be, depending on the direction of force, line of force of action, there are occipital headgear, cervical pull headgear, combi pull headgear, and depending on direction of force and the anchorage from where we are taking the anchorage, it will be defined in these 3 types. So component of headgear are, this is a headgear assembly with the safety modules. Here is the face bow assembly, through which the forces are delivered to the maxillary dentition. Here the elastic strap, this is neck pad. So this is the whole assembly of a headgear. So before going to headgear, we must know through headgear we are applying and force through to the maxillas, so that taking the anchorage from the our occipital region, so that we can control or restrict the growth of the maxilla in a forward direction. So as we all know, the changes what we want greatly depends on from where our line of action of force is passing through, and that is dependent on the center of resistance. So in the maxillary first molar region, for the maxillary first molar, the center of resistance lies near the maxillary first molar lies at the furcation area. For the entire maxilla, the center of resistance exists posterior superior aspect of zygomatically-maxillary suture, as it is here. And for the entire maxillary dentition as a whole, the center of resistance exists between the premolars. So whatever moment we want, if we want to move the entire maxilla, our center of our line of force should pass through the center of resistance, through the center of resistance above or below in relation. So depending on that, the tipping of the palatal plane or entire maxilla will occur. Dentition, for the similar rules will be applied for the whole of the dentition. So this picture again shows the center of maxilla in the different region. This is the for the center of resistance for the maxillary molar. This shows the center of resistance for entire maxillary dentition, and this A point shows the center of resistance of the entire maxilla along with the skeletal base and along with total dentition. So we can see this arrow. This is line of, if this is a line of force of action, if this is passing through the center of resistance of the maxilla, the whole of the maxillary base will be pushed in the backward direction, controlling the growth of the maxilla. So selection of headgear, it depends on in which direction we want to move the maxilla. It is will it be counterclockwise or anti-clockwise or clockwise direction. So if the occipital headgear with outer bow posterior to the center of resistance will create the intrusion of teeth and steepening of occlusal plane, whereas an occipital headgear with outer bow anterior to the center of resistance will create intrusion of teeth and flattening of occlusal plane. Similarly, cervical headgear, this with the outer bow lower will produce the extrusion of teeth and steepening of occlusal plane, whereas cervical headgear with outer bow, which is very much high, will produce the extrusion of teeth and flattening of occlusal plane. Combi pull headgear, will create, we have again here is a options. So combipool headgear with outer bow above the center of resistance will create distal force and flattening of the occlusal plane. Headgear with outer bow below the center of resistance will create distal force and steepening of the occlusal plane, whereas combipool headgear with outer bow through the center of resistance, that is through the center of resistance, if it will pass through distal force with no change in occlusal plane. That's what I was saying. There will be no movement in the clockwise or counterclockwise direction. Only the backward movement of the maxilla will occur with this type of combination. So selection of headgear will totally depend on our requirement. There are different type of face bows, like standard face bow, loop style face bow, short outer bow, etc. And we can choose depending on our requirement, whatever we require. So about the headgear, there will be a separate lecture by which you can go through. This is the, I am telling about only the options which can adapt for the correction of class 2 malocclusion. So headgear is the one option to restrain the growth of maxillary base. Second is to promote the skeletal growth of mandible. There are functional appliances which we can choose. So these appliances are designed to change the patient's pattern of function, alter the jaw relationship, and reprogram the neuromusculature, thus altering the functional matrix of the face. What will be the criteria for the appliances to select is the indication, that is the indication for functional appliance includes patient must be in the growth phase, skeletal class 2 malocclusion which are due to decreased size of mandible, not because of increased size of the maxilla, because with these functional appliances we are not able to constrain the growth of the maxilla to a greater extent. So the patients which have a decreased size of mandible are good indicators for functional appliances, and the growth pattern will be should be the horizontal growth pattern. So contraindications will be post-growth phase, problems associated with the prognathic maxilla, class 2 due to normal size and retrieve position mandible, that is that will give the unfavorable prognosis, gross irregularities in individual tooth positions. So there must be well aligned arches before we go for the treatment with the malfunction appliances. Proclined over anterior teeth are contraindications. Vertical growth pattern again in a contraindication. So if you want to go for the functional appliance, first check the VTO. VTO is a visual treatment objective. That is, after giving the functional appliance therapy, how much correction, what type of correction we will achieve. If after proclining, for keeping the mandible in a forward direction, if the profile is improving, so it will be set to as a positive VTO. But if the profile, there is no improvement in the profile, the VTO is negative, and that will be a contraindication for the malfunction appliance. So construction bite is taken and the appliance is fabricated. In case of class 2 div 2, an H2H construction bite is registered to correct the distal occlusion, and eruption of lower molars will correct the vertical dimensions as well in class 2 cases. Otherwise, in class 2 division 1 cases, one step or two step bite registration can be done according to the need. Activator is a malfunctional appliance which is indicated in mild to moderate class 2 malocclusions with deep bite and horizontal growth pattern. It is contraindicated in crowding cases, proclined over anteriors in vertical growers. Bionator is appliance given by, also known as a Barter's appliance. It changes the tongue position, keeps away the buccal musculature, creates the lip seal, and causes the mandibular protrusion. Pioneer therapy will lead to decreased skeletal convexity, reduced overjet overbite, decreased facial convexity, and increase in ventolabral angle. Coming to the functional Frankel functional regulator, this is indicated in class 2 cases with abnormal perioral muscle function. The appliance is used as oral gymnastic appliance to help in overcoming abnormal perioral muscles activity and rehabilitates the muscles and to establish proper lip seal. There are 5 types of Frankel appliances, out of which Frankel FR1 is used in the treatment of class 1 and class 2 div 1. So in the 1 there is a 1A, B and 1C. 1P and 1C are used to correct the class 2 division. Div 1. 1B where the class 2 division 1 where overjet does not exceed 5 mm. 1C where overjet is more than 7 mm. And FR2 in the class treatment of class 2 div 1 and div 2 cases. Chin block appliance is the most common appliance for the correction of class 2 division 1 malocclusion in the growing phase. In class 2 malocclusion, to modify the occlusal inclined plane in distal occlusion that have a distal component of force that is unfavorable for normal forward mandibular development. In patients with poor tolerance to other functional appliances, it is an appliance of choice. Mechanism of action involves forces of occlusion are used as functional mechanism to correct the malocclusion. During the for the class 2 div 2 malocclusion, a sagittal twin block appliance can be given. Screws are put in the palate for arch development in the anteroposterior direction also. So coming to the orthodontic camouflage. In the orthodontic camouflage, if the growth is over, we have to no leeway for the growth modulation. We will go for the orthodontic camouflage, and the decision here is mainly governed by the amount of tooth size arch length discrepancy. We have 2 modalities: extraction ortho treatment or non-extraction, and that will be governed by the amount of tooth size arch length discrepancy. Here is the various analysis, model analysis, which will tell about the amount of arch length discrepancy that can be named as Carey's arch perimeter analysis, Ashley-Ho analysis, Pons analysis, Karkos, and Bolton analysis. As a whole, they will tell about the exact amount of the arch length discrepancy and help us to opt the which type of extraction or non-extraction modality we want to opt. Camouflage means to jaw discrepancies is no longer apparent. So for the 3 pattern of tooth movement can be used: non-extraction with class 2 elastics, retraction of maxillary incisors into premolar extraction space, or the distal movement of upper teeth as a non-extraction modality. Treatment of malocclusion with underlying mild or moderate jaw discrepancies, which can achieve a good dental occlusion without extraction of certain teeth to mask a skeletal problem. Various methods of gaining space can be employed depending upon the amount of tooth size arch length discrepancy. So one is the molar distalization, when the arch length discrepancy is mild and the patient is has a horizontal growth pattern. We can go for the molar distalization along with the certain other indications which we have to see before opting the ideal case. So indications for distalization will be end-on molar relation with mild to moderate space requirement, cases with less than a full cusp class 2 molar relation with good soft tissue profile, good borderline cases, as I said, mild to moderate space discrepancy, and with missing third molars and second molars has not yet erupted. The best time to go for the molar distalization procedure is when the second molar is not present in the oral cavity. And growth is also one indication to hold for the growth modification. Contraindications will be severe class 2, vertical skeletal discrepancies, patient with severe crowding or protrusion of incisors in whom extraction spaces would be required to align remaining teeth. Means there is much more arch length tooth size discrepancy. And patients with excellent remaining growth potential. If growth is remaining, don't opt for the distalization procedure. Patients with severe skeletal discrepancies are also a contraindication. So methods of digitalization will include certain appliance can be done with the headgears, Wilson biometric arch, modified Nance lingual appliance, molar digitalization with magnets, and use of super elastic night tie. Here, night tie double loop system. Here you can see Jones jig. This is the appliance Jones jig. The pendulum appliance, which is an intraoral appliance, fixed appliance that can efficiently digitalize the molar. Fixed piston appliance, we can see here the K-loop appliance. This is a K-loop given by Varun Kalra, and it can be used to digitalize the molar. Distal jet, lowered molar digitalizing appliance, and pendulum appliance. These were the few names that with that we can go for the molar digitalization procedure to create a space, gain the space for the correction of class 2 molar. Coming to the camouflage by extraction treatment. So we have we can have a different options for the extraction, but the most commonly extracted tooth is the all first premolars, so that retraction of maxillary incisors into premolar extraction space can be done to relieve the crowding and to correct the incisor inclination, and also to bring the lower molar forward to achieve a class 1 molar relationship and a normal overjet and overbite. The cases where there is an extreme protrusion exists, so we can we have to retract much more in the anterior segment. So to correct the extreme overjets, there will be a option to extract the maxillary first premolars only, and leading to retraction of incisors in premolar space without lower extraction, so that molar will be in the class 2 molar relations, and then overjet will come to the normal, and the class 1 canine relationship can also be achieved. Next extraction option may be the extraction of maxillary first premolar and mandibular second premolar. With the use of class 2 elastics, bring the lower molars forward and retract the upper incisors. Class 1 molar relationship will be achieved, class 1 canine relation and normal overjet can be achieved with this combination of extraction. Coming to the surgical correction. Surgical correction of class 2 can be opt for in severe discrepancy cases, severe skeletal discrepancy cases that cannot be resolved by the orthodontic treatment alone, or in adult patients where no modulation or can be done. Young patients with extremely severe or progressive deformity will be the suitable candidate. Good general health status of the patient should be there for the surgical correction. So likewise, in for the orthodontic treatment, the certain additional cephalometric assessments are required to go through. There are certain useful ratios that must be considered, like SN plane, SN length to maxilla to mandibular length. Usually this should be in the ratio of 20, 14, 21. Corpus to ramus 7:5, as a middle face, lower face, that is Jarabek, and the Jarabek ratio, and the nasal to labial 1:4 ratio. These are the useful ratios that should be considered before going for the surgical strategies, so that there is discrepancy exists in these ratios. This will tell about the which area is at the fault and where the correction is required. Here the SN plane 20, income S20 is to maxillary plane 14 and the mandibular plane 21. And this mandibular body to ramal height 5:7 ratio is a normal ratio. For the nasolabial angle 1:4, for the upper nasolabial angle and the lower nasolabial angle. If discrepancy exists, that will give us about the idea. So surgical successful management of combined surgical and orthodontic treatment requires the integration of pre-surgical orthodontic phase, then surgical phase, and the post-surgical orthodontic phase. Dental compensations are removed before surgery and the teeth are properly located in relationship to the individual skeletal component. Pre-surgical orthodontics aim is to position the teeth in the arches so that the dental arches become compatible, facilitating their proper placement during the surgery. Main tooth movement commonly required include intrusion, leveling, derotation, closure of space, correction of anterior posterior crossbites, and coordination of the dental arches. So, if at all extractions are required during the compensation phase, that is pre-surgical orthodontic phase, extraction of upper second premolar and lower first molars, if the case were to be treated orthognatically. The objective of this extraction pattern is to establish a full cusp class 2 molar and canine relation. Lower first premolars are preferably extracted to allow the leveling and correction of anterior proclination. That is, we are not going to correct the molar relationship in the pre-surgical phase. We are just getting it a full cusp class 2 position with a proper overjet, and alignment and leveling of the arches should be done. In the mandibular arch, accentuated curve of Spee can be corrected by two methods, either by the intrusion of the incisors or extrusion of the premolars. Basically, the desired final post-surgical position of the incisor should be achieved pre-surgically. If the incisors are elongated and face height is normal or excessive, they must be intruded to prevent problems in controlling face height at a surgery. If face is short and distance from lower incisal edge of the chin is normal, labeling by extrusion of posterior teeth is indicated. Mid-face surgeries, the few names: Leaford 1, maxillary osteotomy. There, the maxillary posterior repositioning and superior repositioning can be done. Maxillary anterior segmental osteotomy means dentoalveolar proclination and bimax protrusion. Interdental corticotomy in class 2 D1 cases with maxillary prognathism anterior spacing. Mandibular surgeries can be mandibular deficiency in cases of class 2 can be corrected by bilateral sagittal split osteotomy, C osteotomy, L osteotomy, and the vertical ramus osteotomy. Thank you. This was all about management of class 2 in brief. Thanks.